अमल सर नमस्कार। अक्षय सामल सर म्यूट अच्छे आपनकर म्यूट अनम्यूट करन सामल सर अनम्यूट करी कौन अब दीटा जगह रहे मैडम कर सर अपना दीटा डिवाइस रे लॉगिन करछन मैडम कर ना देखो जे अपन ना म्यूट अच्छे म्यूट सर म्यूट अच्छे अनम्यूट करन अनम्यूट करन
हां अरे मोर मोबाइल टच मैडम उठे कंप्यूटर अछि रोटरी क्लब रो
सर सर
हां सीटा लगला
अच्छा सर
ए बड़ो सर
ए सर नमस्कार बंद खुशबा बंद कर
खाली मो ये टाणी लगे दो ना सरजो ना हेलो नमो एटा नहीं सेरा
सर नमस्कार
सर नमस्कार मुझे केतेबेलु कहलिनी बड़ सर मु वो
सर
कोन
स्थिति पर नमस्कार
सर नमस्कार आचार्य सर नमस्कार
सर नमस्कार
प्रेसिडेंट ऑफ द प्रेसिडियम
ए तुमको चार्ज दे दो छी हाउ प्रेसिडेंट दे परिबी तमे तो
प्रेसिडेंट ऑफ प्रेसिडियम
बुझले सर
पीसी रथ भाबे सीएसआई प्रेसिडेंट पीके साव छाड़थला
कोनला
अमल सर नमस्कार
नमस्कार
कोई
कोई
रथ भाबे प्रेसिडेंट सीएसआई
आचार्य सर नमस्कार
भाई
अभिनंदन सर
नमस्कार
नमस्कार
इटा मोर बोले ये होनी
हां सर जयप्रकाश सर नमस्कार जयप्रकाश सर
नमस्कार नमस्कार
सर नमस्कार सर नमस्कार
सर
सर नमस्कार
सर ए घर को आसी गलेनी तो
ए लाटा दोलटी आई
हेलो
हां सर
मो कथा सुना
हां सर सुना
कोन सुनी करछु
सुना होची देखा भी जाउची
ए विशु सर मु सुबुची
नमस्कार
को
हां एकदम भला
अच्छा चल
अच्छा
ई कोन
गॉट इट लिख दे क्लिक कर दे
क्लिक कर हां गॉट इट हां ठीक है
ना आरंभ करता
हां टिके रहन सर टिके सत्य सर्वे का आस्यम बाजीराव सर नमस्कार
सर नमस्कार
नमस्कार
बाजुरिया सर नमस्कार
बाजीराव
सर कौन करिया कौन सामल सर एकदम
सर नमस्कार एकदम
नमस्कार कहली किछि तो कहू
नमस्कार के
चापक लिंक कोणी की आयटी को पासवर्ड
तो चाणक्य
एक मैंने पूछ ऑडियो
चाणक्य सत्य सर गोटे फोन लगा
हां सर बताओ सर
एटा गायत्री दास
हां सर आपण ताऊ रीनेम करि परिबे सर तो थाउ सर गायत्री दास सर लेबे हम जानिलु सर किछ असुविधा नहीं सर थाउ सर
ऑडियो
गजरे सर अनम्यूट करम सर
Adjust करना
ସକାଳୁ ସିଏ ବି ବ୍ୟସ୍ତ ହବ
napkin
सर
napkin
चले
उधार के बाद उन्हें एडजस्ट करना कल पेश
शिशु सर नमस्कार
या रिवर्स करते हुए ठीक है
अरे सर नमस्कार
नमस्कार सर
नमस्कार सर आसीगले प्रेसिडेंट सर
ए प्रेसिडेंट सर केतेबेले बसचंती अपेक्षा करके प्रोफेसर मिश्र को
प्रेसिडेंट सर आज नाली
आज
आज फुल ऑफ फोटो नहीं
नाइ म फुल
सर नमस्कार प्रोफेसर निकोलस आसी
बोकर सेठी बॉयच तो दे दे मु इथि बस्ती और एट कहि हल्लो कहि तो ए उन्ना फोन को हल्लो को उन्ना उन्ना दस
दीपक
कांटे दे से हल्लो को
यार हेलानी जळलानी आ कोन एटा तो जळिलानी काई जळि परलानी
मो नाटा भूल ले चढ़ी जाई छी गायत्री दास
सर हम जानि सर
सर कोन सर
नो प्रॉब्लम
सेटारे कोन अछि सर
नहीं नहीं मु कोहि
हम तो जानि जे
सर नमस्कार
नमस्कार
सर नमस्कार रवि कहूची
हाँ अरे
सर रवि कहूची सर
मोर
नमस्कार
नहीं पर नथली
डॉक्टर रविनारायण का तालचेर सर
हाँ सर नमस्कार
सर नमस्कार
गजरे सर नमस्कार
समत को जिंदे कर
गजरे सर
अनम्यूट करना है डॉक्टर बाजुरिया
मैं तमरो दे ऑडियो डिवाइस
सर नमस्कार
शॉर्ट क्यों हुआ ये सर जी
बनी अच्छी थी हाँ सब था
डॉक्टर आचार्य गुड इवनिंग
सर गुड इवनिंग मुझे तो कहली नमस्कार सुबुद नथिला
विजय विजय काई
विजय काई दिसुनी
तो डाक्टर डका डका ताको
ओके गुड इवनिंग
नमस्कार नमस्कारम
ए बड़ सार गोटे एक्चुअली बड़ सार
फोटोटा खाली छाड़
इवनिंग टू एवरीबॉडी
डॉक्टर
गुड इवनिंग
गुड इवनिंग सर
ऑडियो
डॉक्टर श्यामल
सर नमस्कार नमस्कार
सब बड़े
सर नमस्कार
पछरे फोटोटा देखा जाउची ना जगन्नाथ
जगन्नाथ से जो स्नान पूर्णिमा फोटो खंचा देइतला भक्त जणे स्नान पूर्णिमा फोटो
दीपक ओरिजिनल ना फोटो रे अछु अच्छी नमस्कार
फोटो रे अछि
ऐसे फोटोटा लगे दी पड़े मजरे मजरे प्रेसिडेंट सर सेक्रेटरी कोड गले
ए सेक्रेटरी अछंती
अछंती
ना पूरा पूरा
नमस्कार नांती
हां अछंती अछंती आसिले ए
परमानेंट
साउंड लेस कर
परमानेंट
दी
सर ना परमानेंट सर असना पूरा
परमानेंट सर ना दी
ना
वेटिंग परमानेंट साल असलेस ना स्टार्ट करिवा
हां
ए जॉइन कॉलोनी सर
Since all of you are free now, can I convey good evening to everybody?
Sir, namaskar.
Yeah. Good evening.
Sir, namaskar.
Namaskar.
Namaskar, sir.
अनुपम रेडी
Sir, namaskar.
Namaskar.
Dajra sir, namaskar.
नमस्कार नमस्कार सर
Namaskar.
सर आपन को नमस्कार हम केतर पर कोन हां बेली
परमानेंट सर आसिले
हां कोन
सर नमस्कार
प्रेसिडेंट सर परमानेंट सर
सर
आसिले
बहुत तरह नमस्कार कोनी अपन हां कहू ना
मते करछो ना का को
से सर सस्मिता स्वाई का नारे अछंते तो
Namaskar to everybody.
नहीं नहीं एबे डॉक्टर जयप्रकाश लिखा रहा
Huh?
ए सत्य सस्मिता नाराज
सत्य काई
सत्य सस्मिता स्वाई नाराज
हां
सत्य देखा जाउनी कोडे गला
हां दिसलेन सर आपन को तळे
वो परे हो देखे को
आपन को तळे लेफ्ट को अछि
right. I am not that techno savvy. I'll ask somebody to adjust it. सत्य सर बोले आपन को तोले
Sir, नहीं नहीं सर 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 जो खोजुचंती एक्चुअली नाटा मु चेंज करतु बस
अरे गोटे से ये व्यू रे नियंतो सेतिर आछि पार्टिसिपेंट रे गोटे ये अछि गैलरी व्यू सेतिर आछि
Professor JP Dasan, what a request. Can we see Madam? We have not seen for a long time.
मैडम कैन यू सी मैडम
म्यूट कर दो
तमे रहिलो तालचेर रे हम तो बंदी रहिलो कटक रे अब कोन
अरे एटी जत्ते सब अछंती समस्त फोटो रे बंदी अछंती ठीक खोला ना दी सर
मैडम नमस्कार
नमस्कार
रवि
Madam, namaskar.
समस्त दुखने समस्त
मैडम नमस्कार
नमस्कार मैडम नमस्कार
नमस्कार
सत्य चेंज कर दिले तांकर सुस्मिता रे सत्य होई गेल
चाणक्य
करू जाऊ येला तो आउट हबो ना हे छी
चाणक्य
हनुमंजन रेडी
सर
चाणक्य
सर कौन सर
हाँ से जर स्पीकर्स वन का लॉगिन करे अपन डॉक्टर पीके साहू
आउ टिके वॉल्यूम बढ़े हो कि
ठीक है सर
सर आपण को पाखरे सहीठी बढ़ेबो आपण को डिवाइस
एटी सर मैडम कहले डे बढ़े देबे फोन रे
नहीं आउ से धरले पुणी कुआडे कटि जीवो
हमको सर परिष्कार सुबुची
अच्छा अच्छा भलो
दीपक गुडे बढ़िया
अरे दीपक सीनरी दीपक सीनरी
लोकेशन के समुद्र आर्टिकल टाइमर पाके मिशन आउट लासिरा
चनन
कोड सीनरी नहीं गाड़ी उठे बोले कौन दी ओते सोन और
गोवारे अछि बोल दीपक तो गोवारे अछि देखाउ
कौन
बीच रे बस
ए कौन ला रे ए दिल्ली पेटी पर ये चलची कौन कॉन्फ्रेंस कौन को तुम तो लोना पी लिखा हो जो କଣ ଥୁ ଦିଅ
Okay, sir. Mute.
ଦୁଇ ଜିନିଷ
ସତ୍ୟ
ଜଣ ହେଇଛନ୍ତି। ଏବେ ଆଉ 10 ମିନିଟ୍ ପରେ ଆରମ୍ଭ କରିବା ନା କଣ?
ନାଇଁ ନାଇଁ ଷ୍ଟାର୍ଟ କରିବା ନା।
ନାଇଁ ମ ଆରମ୍ଭ କରନ୍ତୁ ଆସିବେ
ହଁ ଆରମ୍ଭ କରିବା।
ବହୁତ
ହଁ।
ଟାଇମ ଲାଗିବ
Deepak, other speakers have joined. First speaker joined or not?
First speaker has
Manoranjan
joined.
is
କାମ
there?
ବହୁତ ଅଛି।
हाँ first speaker has joined. Chairpersons डॉक्टर बाजोरिया खाली अछंते। ओके chairperson ଅଛି डॉक्टर बाजोरिया अछंते।
ଦେଖିଲେ ବେହେରା ସାର୍ ଅଛନ୍ତି କି?
डॉक्टर बेहरा कोन लॉगिन करि पार नथिले मते कहले।
ତାର ଆମର ଏ ଫାଲତୁ ଜିନିଷ ସରିଲା ବେଳକୁ ଲଗ ଇନ କରି ଯାଇଥିବେ
Live.
इंट्रोडक्शन
पंचानन साहु भी इतना
आरंभ ହେଇଯାଉ
सर गोटे काम करबा लेट अस स्टार्ट ऑन प्रोफेसर जेपी दास आरंभ करे हम स्टार्ट करिया सर
ଆରମ୍ଭ କରି ଆରମ୍ଭ କରି।
हाँ so good evening everybody I welcome all to this CSI CME this will be on lipids this is one of our series of CMEs so at the outset I will request our senior most member our teacher Professor JP Das to please officially inaugurate it sir JP Das sir to please speak a few words.
Shall I start?
Yes sir.
Yes, sir.
President CSI Odisha chapter, fellow cardiologists, primary cardiac physicians, ladies and gentlemen. This is a very interesting topic and very vital topic because most of the cardiovascular deaths in the world occur due to dyslipidemia. The culprit oxidized LDL has been targeted and the therapy about controlling that is being discussed. There should be a very frank and very clear discussion on this. But we have other means also like the ezetimibe. I don't know, I have no experience on ezetimibe. Then there are triglycerides, which we thought are benign, but now are very important for cardiovascular deaths. And LP small a, NAS and NAS has been talking about it for the last 30 years. I don't know what progress we have made. But it is true that the risk factor of cardiovascular disease, the LDL cholesterol, should be controlled adequately. And we do not know yet how long we will continue, in what dose we will continue. We give 80 milligram of atorvastatin in the beginning when a patient comes with myocardial infarction. How long it continues in his life, we do not know. And then another thing is that there are new methods of therapy that is coming up, like the RNA mechanism, like the genetic mechanism, we explored. I am glad that one of our doctors, Dr. S.S. Mishra, is studying the intima media thickness, which is a guide, proper guide to the control of dyslipidemia. But I would like him to work more. And is Satya there?
Yes. Yes sir.
Satya has come.
Yes.
S.N. Rautrai. Is he there?
sir.
And I was thinking that we have so many DM trainees now that 2-3 papers on dyslipidemia should come out every year and probably explore the possibility of measuring the intima media thickness for the progression of the disease. One can buy these, I think, these consoles. I don't know whether they're available in SCV and Barampur, but if it is not, then that should be included because it will be a very good study. And the progression of the disease needs no alarm because it's going ahead and we are not able to control that for a long time. But my students in New York say that the incidence of myocardial infarction and the procedure angioplasty has come down drastically. They are getting healthier. So we must discuss these very clearly and set up the guidelines. Symposia like this are not for cardiologists. They are meant for primary cardiac physicians. If they are not active, they are not knowledgeable, our role is minor in that because we are not following patients on a long-term basis. So I think we must pay attention to this and set a clear basis to the primary cardiac physician what to do, how long to continue, what is the role of LPA small a and ezetimibe and also triglycerides. So all these have to be told to them as a take-home message, and that will be effective. Thank you very much for sharing with me, and I wish the function a grand success. Thank you.
Thank you, sir. Thank you very much. Now I will request our president to please welcome the delegates. Dr. Acharya.
Thanks. Thank you, Dr. Mishra. Dear friends, we are a very small group with all known persons. I am just to welcome my friends with whom we are associated with for so many years. Now, at the outset, I am to first welcome and introduce our learned professor, Professor J.P. Das, who is the first most revered teacher and the first cardiologist of our state, and who has brought the idea of cardiology to our state. Now, then will be, I welcome our respected moderator, Professor S.N. Rautray, Professor and Head of Cardiology, SC Medical College. He will be moderating the subject. He is our permanent invitee and the backbone of our Odisha CSI. Then I welcome our respected chairpersons like Dr. S.S.L. Bajoria, Professor Mrutyunjay Behra, Professor H.N. Mishra, and Dr. Panchanand Sahu. They will be sharing the session and give their valuable opinions. The honorable speakers, Dr. Manabhanjan Jaina, Dr. Madam Chabi Satpathy, Dr. Prashant Kumar Sahu, and Dr. Deepak Ranjan Das will be giving justice to the topic, that is lipids, and what is the role of statin and how statins help and all that. Professor Das has given a very nice introduction, how lipids are the culprits. The honorable panelist, Dr. R.S.N. Murthy, our immediate past president, Professor A.K. Samal, and Professor S.S. Mishra and N.K. Mishra will be giving their own views over, with the literature, over the statins and the lipids, all that, what is going on. And lastly, our dynamic secretary, Dr. B.R. Mishra, will conduct the CME in this symposium. In this symposium, we'll discuss different aspects of lipids which will be addressed by the moderator, Professor S. N. Rautray. So without further delay, because it's a very long hour program for 2 hours, may take a little more, I request our Honorable permanent invitee, Professor Rautray, and Honorable Secretary, Dr. B.R. Mishra, to proceed with the program of this symposium. Dr. Mishra, please.
Thank you, sir. Our moderator, Professor S. N. Rautray, I think I did not introduce him. He is known to everybody here. So I will request him to start the symposium.
Yes. Thank you, Bisu. Dr. B.R. Mishra, am I audible?
Yes, sir.
Yes, very much.
Yes. Honorable Professor J.P. Das, Dr. Bajaria, Dr. P.K. Acharya, and all other seniors. Because there is sufficient introduction to the topic is already there. I think regarding the chairpersons, actually Dr. H.N. Mishra rang me. He will join little late. He is on way. He will take some time. Dr. Bajaria sir is there.
Dr. Behra is there.
Dr. Behra sir was joining. I do not know. He has already finding problem.
He's on the iPhone. He's there on the iPhone.
Sir. And Panchanan, you are there?
No, yes,
Anyway, our first speaker is Dr. Manavanjan Jena. He is presently associate professor at IMS and some hospital, Bhubaneswar. I think without wasting much time, again, I will just inform regarding the panel. Because Dr. R.S.N. Murthy, he is in problem, he is not able to join. Already he is telling that no BSNL connection in his area. I could not contact Dr. N.K. Mishra. I have circulated certain questions to all of them, but if time permit, we will discuss, or they will give, whoever may be present, they will give their view, overall view on the topic. So with this much, I will now hand over the session to Professor Behra and Dr. Bajaria.
Yes. Without wasting much time, it's already late. The program was to start at 7 o'clock. Now it is 8 o'clock. So let us start.
No, it was
7:30, 7:45.
I got a circular initially which showed that it starts at 7:15. 7 o'clock, Dr. Japidas will inaugurate. 7:15 it will start. Now the things. Anyway, it doesn't matter. Let us not waste time. I will request Dr. Jana to speak on lipids and ASCVD risk. In fact, we had some type of discussion yesterday with Dr. Mishra also in one of the webs. I think go ahead. Dr. Jana, please. Dr. Jana.
Yes. Manavanjan, you are not audible.
I'm MacBook अच्छी रे और आपको MacBook अच्छी है
Now, Rudanda has joined, I think.
Sir has joined.
Am I audible, sir?
Yes, you are audible.
Yes. Audible.
Yes, sir. Just let me, sir, share my slide first and then, sir. Sir, is slide visible?
Yes.
Thank you, sir. Respected my teachers, Honorable J.P. Das sir, and respected teacher, sir. I'm fortunate enough and I'm blessed to share the dais with my stalwart teachers who are just like my father figure, not only in age but also in academics. So I am fortunate enough to present my program, my CME in front of my teacher. So my topic is a very though it looks like a very simple one, but it's a very vast topic. So whatever slides I have collected to discuss in front of you, sirs, just in Indian point of view. So just I'm going to present my slides as lipids and atherosclerotic cardiovascular risk. So the burden of atherosclerotic cardiovascular disease in India is alarmingly high and is a cause of concerns. Indians are at high risk of developing ASCVD, usually get the disease at an early age and have a more severe form of disease and have poorer outcome as compared to the Western population. So epidemiology of dyslipidemia in India, the global burden of metabolic risk factor study reported trends in total cholesterol levels in different countries and world regions from the years 1980 to 2008. The available evidence suggests that the cholesterol levels are steadily rising among Indians, a trend which is just opposite to what is observed in Western population. Compared with Western population, Indian tends to have higher triglyceride levels and lower HDL levels, but the total cholesterol and LDL cholesterol levels are generally lower side. Among various lipid markers, the ratio of ApoB and ApoA1 appears to be the best indicator of cardiovascular risk. So atherosclerotic cardiovascular risk categories, they have categorized into very high risk, moderate risk, and low risk. The very high risk, the conventional risk factors are pre-existing ASCVD, diabetes with evidence of end organ damage, with more than equal to 2 other major ASCVD risk factors. Non-conventional risk factors are none. High risk, where the more than 15% risk of ASCVD death, MI, or stroke over a period of 10 years. So here there is more than equal to 3 major ASCVD risk factor, diabetes with 1 or 0 or 1 other major ASCVD risk factors, and no evidence of end organ damage, CKD stage 3, 4, 3B or 4, familial hypercholesterolemia except familial homozygous hypercholesterolemia, extreme of single risk factor, that is LDL cholesterol more than 119 milligram, strong family history of premature ASCVD, and heavy smoker. The non-conventional risk factor are the coronary artery calcium score more than equal to 300 Augustin's unit, non-stenotic carotid plaque, and lipoprotein small a more than equal to 50 milligram per deciliter. The moderate risk factor, the risk is 5 to 15% of ASCVD death, MI, or stroke over a period of 10 years. The 2 major ASCVD risk factors. The non-conventional are the CSC score 100 to 299 Augustin's unit, increased carotid intima media thickness, the CIMT or aortic pulse wave velocity, and the lipoprotein small a 20 to 49 milligram per deciliter, metabolic syndrome. Low risk is less than 5% risk of ASCVD death, MI, stroke over a period of 10 years. The 0 to 1 major ASCVD risk factors. Non-conventional risk factors are none. So what are the secondary causes of lipid disorders? The secondary causes are the undesirable lifestyle conditions like excessive alcohol intake, lack of physical activity, fat-dense diet, primarily saturated fats, high carbohydrate diet, and high sugar intake, malnutrition. The medical conditions are overweight, obesity, metabolic syndrome, pre-diabetes, uncontrolled diabetes, hypothyroidism, pregnancy, CKD stage more than equal to 3, especially with albuminuria, nephrotic syndrome, cholestatic disease of liver, lipodystrophy, paraproteinemia, gamma globulinemia or multiple myeloma, chronic inflammatory conditions like rheumatoid arthritis and SLE. Medications among the cardiac drugs are the beta blockers, thiazide diuretics, atypical, and other are the atypical antipsychotic drug, Taxol's derivative, many group of drugs which causes the dyslipid disorders. So atherosclerotic cardiovascular disease risk factors, the major risk factor are the advanced age, where there is increased total cholesterol, increased non-HDL cholesterol, increased LDL cholesterol, low HDL cholesterol, diabetes, hypertension, chronic kidney disease, cigarette smoking, familial. And additional risk factors, family history of hyperlipidemia, increased small dense LDL cholesterol, increased apolipoprotein B, increased LDL particle concentrations, PCOS, fasting and postprandial hypertriglyceridemia, dyslipidemic triad. Non-conventional are increased lipoprotein small a, increasing clotting factors. Many risk factors are increased uric acid, increased triglycerides, remnants, many things are there. So what is the prevalence of dyslipidemia in India? Particularly the Indian Heart Watch multi-site studies suggest that the cholesterol levels more than 200 are present almost in both men and female is almost 20 to 25%. But LDL cholesterol more than 30 is similarly in male it is 15% and in female it's 16.3%. But one thing we can see, this HDL cholesterol is very high in HDL cholesterol level less than 40 or 50 is, this percentage is very high in case of female, where it is 53%, where in case of male it is 34%. But on other aspect, the triglyceride to HDL ratio, triglyceride level more than 150, the male supersedes the female, the 41% to 31%. So how should we measure the lipoproteins? Lipoproteins analysis is done 12 to 14 hours before of fastings. Triglycerides and HDL cholesterol can be measured fasting or non-fasting. LDL cholesterol equal to total cholesterol minus VLDL into 1/5 of triglyceride minus HDL. The validity depends on the triglyceride level less than 400 milligram per deciliter. Measure directly, patients say profound hypertriglyceridemia. There is errors in triglycerides, LDL and total cholesterol can affect the values. Non-HDL cholesterol equal to total cholesterol minus HDL cholesterol. All cholesterol in atherogenic lipoproteins includes LDL, lipoprotein A, IDL, and VLDL. Acute phase response, that is in MI, surgical trauma, or infection, can also reduce the level of total cholesterol, HDL, LDL, ApoA plus B through impairment of hepatic lipoprotein production. So it also simultaneously raises lipoprotein small a and triglyceride levels. So approach to atherosclerotic cardiovascular disease risk assessment in India. The step one is the identify patients at a very high risk of having cardiovascular events, pre-existing ASCVD, which may be in the form of any of the following: history of MI or documented CAD, history of ischemic stroke or TIA, or hemodynamically significant carotid plaque. Atherosclerotic peripheral arterial disease includes the ankle brachial index less than 0.9, atherosclerotic aortic aneurysms, and atherosclerotic renal artery stenosis. Diabetes with 2 or more of the major ASCVD risk factor, evidence of target organ damage, and familial homozygous hypercholesterolemia. Step 2, look for various conventional and non-conventional risk factors. If age more than 45 years in males and age more than equal to 55 in females, family history of early ASCVD with less than 55 years of age in males, first degree relative, or less than 65 years of age in female, first degree relative. Current cigarette smoking or tobacco use, high blood pressure, or low HDL level. Step 3, the estimate lifetime ASCVD risk in all low risk individuals. The lifetime ASCVD risk should be estimated in all individuals who are considered to have low 10 years ASCVD risk. So this slide I've already discussed previously, then no need to go through the slides. So treatment goal and statin initiation threshold according to ASCVD risk categories are the very high risk. The treatment goal is less than 50 and non-HDL treatment goal is less than 80. Similarly, we should consider drug therapy if LDL cholesterol level more than equal to 50 or non-HDL cholesterol level is more than equal to 80. Similarly, for high risk patient, the LDL goal should be less than 70 and a non-HDL goal should be less than 100. And therapy should be started for both cases if LDL cholesterol is more than equal to 70 and non-HDL more than equal to 100. Moderate risk, the LDL cholesterol levels should be less than 10, less than 100, and non-HDL is less than 130. And similarly, the treatment should be start if LDL cholesterol levels should be more than 100 and non-HDL more than 130. Low risk, similarly, the same thing as moderate risk, and the therapy should be started if LDL level more than equal to 130 and non-HDL level should be more than equal to 160. So non-conventional cardiovascular risk factors are coronary artery calcium, which reflects the anatomic presence of coronary atherosclerosis, as calcium is deposited in coronary arteries primarily in the atherosclerotic plaques only. The total CSC score as measured using computed tomography correlates directly with the total atherosclerotic burden in the coronaries. It is recommended as an optional measure for ASCVD risk stratification in individuals who don't have any traditional high-risk features. So carotid intima media thickness, which was already discussed by our
Sir, namaskar.
Deputy sir. CIMT is a widely recognized imaging marker of generalized atherosclerosis. Aortic pulse wave velocity is also an important marker for the generalized atherosclerosis. Aortic pulse wave velocity is a measure of arterial stiffness. Currently, measurement of aortic PWV is recommended during workup of hypertensive subjects, but its roles in ASCVD risk stratification in general is uncertain at present. C-reactive protein is also an important marker for the generalized atherosclerosis. which is a recommended risk factor for ASCVD risk stratification, and lipoprotein small a level is strongly recommended for ASCVD risk stratification in Indian subjects, particularly in those who have family history or premature coronary artery disease. So low density lipoprotein cholesterol, is lower the better? Definitely yes. Various trials and meta-analysis have also shown that more aggressive lowering of LDL cholesterol to 50 milligram per deciliter or less results in significant reduction in atheroma volume and cardiovascular events. Summary and recommendation: LDL cholesterol should be the primary target for the therapy. LDL cholesterol lowering to a low level is essential to achieve the desired reduction in the risk of vascular disease. In those with elevated level of ASCVD risk, lower the LDL cholesterol levels are associated with better outcome. So LDL cholesterol level less than 50 milligram per deciliter is safe. Non-HDL cholesterol, should it be primary target for lipid lowering therapy? Definitely, it is also a very important marker for general atherosclerosis. So LDL, which plays a central role in atherogenesis right from its initiation in the form of endothelial dysfunction to its eventual manifestation as clinical ASCVD. The reduction of LDL cholesterol results in substantial reduction in ASCVD risk. So there is robust evidence from larger scale randomized clinical trial, mostly using statins to this effect. So here are the various plasma proteins. One, you can see this, the ApoB48 chylomicrons and remnants, VLDL, IDL, LDL, lipoprotein small a, and HDL. VLDL, IDL, LDL, lipoprotein small a, among them VLDL plus IDL is equal to atherogenic triglycerides rich lipoproteins. LDL and lipoprotein small a is LDL cholesterol. Both atherogenic triglyceride rich lipoproteins plus LDL cholesterols, they are ultimately called as the non-HDL cholesterol, which are atherogenic lipoproteins. So non-HDL cholesterol is also an indicator for ASCVD risk. It is a total cholesterol minus HDL cholesterol, which I already discussed. Non-HDL cholesterol is particularly informative in diabetes, who tends to have higher triglyceride levels and thus have a greater difference between LDL cholesterol and non-HDL cholesterol. Non-HDL cholesterol seems to predict ASCVD risk equally well, regardless of triglyceride levels. Other advantage of non-HDL cholesterol are there. Estimation of non-HDL cholesterol does not require any additional testings. This is the very important side. So what should be the recommended for Indians? Non-HDL cholesterol, which is equal to total cholesterol minus HDL cholesterol, includes all atherogenic lipoproteins in blood and is therefore a more accurate predictor of ASCVD risk, particularly in patients who have elevated TG and those already on statins therapy. The Lipid Association of India recommends non-HDL cholesterol as a co-primary target, as important as LDL cholesterol for lipid lowering therapy. Monitoring of a non-HDL cholesterol will provide a simple practical tool for treatment decision relating to lipid lowering therapy, since it does not require a fasting blood samples and take care of both LDL cholesterol and triglyceride target. In all individuals, the non-HDL cholesterol should be kept within 30 milligram per deciliter of LDL cholesterol levels. Statins remains the first line of agents for lipid lowering, regardless of whether LDL is the target of therapy or non-HDL cholesterol. Increasing the doses of statins or switching to a more potent statins and intensifying lifestyle measures should be the first step to achieve further non-HDL lowering when LDL cholesterol target has already been reached. Adding non-statin drugs such as ezetimibe or fibrates should be considered when above measures proves inadequate. So the burden of dyslipidemia in ASCVD is the patients with established ASCVD exhibits a higher rate of CV deaths, CV event recurrence, and mortality. You can see from the graph, once the LDL cholesterol level rises, similarly the relative risk for coronary artery disease also increases proportionately. So lessons from statin trial, we have learned that the meta-analysis of the statin trial, 1 millimole, that is equivalent to 39 milligram per deciliter reduction of LDL cholesterol, there occurs 22% reduction in the risk of severe events. If we decrease the 39 milligram per deciliter of LDL cholesterol, then there is a decrease of 22 reduction in the cardiovascular severe event. Similarly, high intensity statin therapy provides a greater protection against the severe events than moderate intensity statin therapy. Here we can see this, the 80 milligram of atorvastatin graph, and another is the 40 milligram of rovastatin. We can see this. See from the graph that the maximum dose of atorvastatin that definitely reduces the death or major risk cardiovascular events. So high dose is very important. Lowering the LDL cholesterol reduces the ASCVD. The cholesterol treatment trialist collaboration analysis showed that for every 1 millimole or 39 millimole per deciliter reduction in LDL cholesterol, there is 20 to 25% reduction in major CV points. So definitely statins are the major major mainstay of the therapy. Here we can see many from the trials which particularly shown the primary prevention like WASCOPs, APCAPs, TEXCAPs, ASCOT, HOP3, Jupiter, where the drugs are used for the primary preventions, and for secondary prevention 4S, KS and lipids, which all shows the definite cardiovascular reduction from these trials. So a high proportion of patients not achieving the LDL cholesterol goal, which is evident from the Sweetheart study. A majority received the high intensity statin therapy, 84%, 72. Statins with ezetimibe is 2% versus 10% at 6 to 10 weeks and 12 to 14 months after MI respectively. Attainment of the ESC or EAS LDL cholesterol goal was about 38% at both follow-up, and proportion of LDL cholesterol less than 70 milligram per deciliter is about 50% in both follow-up. So from this graph, we can see this persons who are not using statins, the percentage of the achieving goal is much less, but persons who are using high intensity of statins, the percentage of LDL cholesterol achieving are the relatively more, but persons who are using any statins plus ezetimibe, definitely their percentage of achieving LDL cholesterol goal is higher than any other groups of patients. So failing to meet LDL cholesterol goal is because of the lack of adherence, drug intolerance, patient's characteristics, lack of lifestyle changes, failure to titrate or switch to more potent drugs or statins, underuse of additional lipid-lowering therapies, inadequate follow-up. So decreased likelihood of reaching LDL cholesterols are mostly happens in female patients, stable angina, obese patients, sedentary lifestyles, and current smokers. But increased likelihood of reaching LDL cholesterol goals, which are happen in type 2 diabetes or CKD patients or very high risk cardiovascular disease. So what are the treatment target goals for cardiovascular disease prevention? The changes in LDL cholesterol goal from 2016 to 2019 guidelines. The 2016 guideline, the very high risk, the LDL cholesterol goal was less than 70. But in 2019 ESC and European Association Atherosclerotic study, they have reduced the LDL cholesterol dose to less than 55 with more than equal to 50% reduction. So previously it was less than 70, now it was less than 55. And high risk group also, the goal was less than 100 milligram per deciliter, but in high risk group it was less than 70. And moderate risk it was less than 115, but in moderate risk in 2019 they have kept it in less than 100. And low risk they have kept it same. So LDL cholesterol target in 2016 versus 2019 ESC guidelines, I have already discussed the slides in previous one. So available guidelines, the treatment targets for LDL cholesterol ESC 2016 or American Association of Clinical Endocrinology 2017. The 2016 ESC or ES guidelines in patients at very high severe risk, established CVD, diabetes, type 1 diabetes with target organ damage, moderate to severe CKD or score level more than 10%, the LDL cholesterol goal is less than 70 milligram per deciliter or more than 50% LDL cholesterol reduction when target level cannot be reached. It is a class 1 level A recommendation. Similarly, 2017 AACE lipid guidelines, they have kept the LDL goal to less than 55, non-HDL goal to less than 80, and FOB goal to less than 70%. So 2019 ESC or ES guidelines, the new lipid goals for secondary prevention, very high risk patient, primary prevention, very high risk patient with no family history, and primary prevention, very high risk patient with family history. The goal is ultimately at least 50% reduction in LDL cholesterol from baseline, and LDL cholesterol should be maintained at less than 50 milligram per deciliters. So 2019 guidelines, the new lipid target and goals are patient with established ASCVD with recurrent events can be different from first events. While taking maximally tolerated dose of statin therapy, the LDL goal should be less than 40 milligram per deciliter, which is a class 2B indication. So lower the LDL cholesterol is better for patient at a very high risk of recurrent ASCVD events. More intensive reduction of LDL cholesterol across severe risk categories. The primary prevention is the LDL reduction should be more than 50% from baseline, and LDL cholesterol goal should be less than 55 are recommended in patients with very high risk but without family history. Similarly, LDL cholesterol reduction should be more than 50% from baseline, and LDL cholesterol goal should be less than 55 per deciliter, and LDL cholesterol should be less than 40 milligram per deciliter may be considered for patient with ASCVD who experiences second vascular events within 2 years. At that time, the goal of LDL cholesterol should be less than 40. These are the slides which I have presented for the lipids and atherosclerotic cardiovascular risk. Thank you, sir. Now over to respected Vishwaranjan sir for further discussion.
Dr. Rautre. Moderator, Professor Rautre.
Thank you, Dr. Jaina.
Thank you, sir.
For an extensive and wide coverage of the subject. Any comments, Dr. Mishra, HN Mishra Hudando Chigi? Hello. Dr. Bajuria, please.
Unmute kariye, Dr. Bajuria. Mute it.
Am I audible?
Yes, sir.
Yes.
You are audible. Dr. Bajuria is muted.
Dr. Bajuria.
Bajuria, sir, unmute kari kaun?
Hello.
Yes, sir.
Dr. Sao Panchanan?
Yes, sir.
Yes.
Sir, I'm
Yes.
sir, namaskar. I'm yes.
Dr. Bajuria wants to say something.
I'm here.
Yes. Okay. Okay.
Hello.
Yes, sir.
You are audible. You are
Hello.
audible. Subhuti.
Am I audible?
Yes, sir.
Yes.
Yes, sir.
Issue.
Yes, sir. Yes, sir. Audible.
Am I audible?
Yes, sir. Yes, sir. Audible.
Acha, nice. Is it a question and answer session or something?
Oh no,
No, sir.
your
Just
comment,
a
please.
comment.
Hello.
Sir, got your comment, sir.
You want to add something, Dr. Bajoria, please?
Hello.
Yes.
Professor Vera.
Yes, yes.
Hello.
Yes, sir.
Hello.
Professor Vera.
Sir, ଆପଣ
Yes, sir.
ଶୁଣୁଛନ୍ତି sir କୁହନ୍ତୁ sir
କୁହନ୍ତୁ,
Hello.
Audible.
Sir, ଶୁଣାଉଛି କୁହନ୍ତୁ.
Yeah, audible, sir.
sir ଶୁଭୁଛି କୁହନ୍ତୁ sir
Hello.
Subhuti.
Hello.
Hello, audible, sir.
Sir, ଆପଣ ଶୁଣା ଯାଉଛନ୍ତି sir?
Hello.
ଆରେ ଆମେ ଶୁଣାଗଲେ କଣ ହବ ସାର୍ ତ ସେଠି
Issue ଶୁଣା ଯାଉଛି ନା ନାଇଁ?
ଶୁଣାଯାଉଛି, sir.
I can't hear.
ତାଙ୍କର
Can you go
sound
back?
ଟା ବଢେଇବାକୁ ପଡିବ sound ଟା ବଢେଇବାକୁ ପଡିବ।
please
Hello.
press the F7 switch.
Vishwaranjan.
Yes, sir. ଶୁଣାଯାଉଛି,
I
sir.
can't hear you.
Sir,
କହୁନି
but
କି
we
ସେଟା
can hear you.
F7 switch ଟା ଟିକେ ପ୍ରେସ୍ କରିକି ସମୟ ଧରନ୍ତୁ the volume of the computer F7 କୁ ପ୍ରେସ୍ କରିକି ଧରନ୍ତୁ।
Panchanan.
Oh,
Sir,
thank
sir.
you are audible. Good, thank you. My question. Can I ask a question?
Yes, sir. Yes, sir.
Yes. Well, the doctor has presented very well. It's really excellent. But all the parameters and everything they have taken is at fasting stage. But in case of many patients, the fasting parameters are normal. But once you take the postprandial samples, there is a big surge in the lipid profile. So should we not consider the postprandial to be more important than only the fasting? One. Similarly, earlier you used to give a lot of importance to the fasting blood sugar in diabetes. Later we find that postprandial blood sugar is more damaging than the fasting. So similarly, fasting lipids may be normal or may be lower than normal, but postprandial surge is too high that might be damaging. So do we have any publications to the effect of postprandial lipid profile, normal values, or where do we collect?
Dr. Jana, please. It's a simple question. Whether you have to take fasting lipid level or a postprandial lipid level, which should be given importance. Dr. Jana, please.
Sir, previously, sir, it was a myth that we have to take the lipid profile in a fasting stage. But now they have seen that certain HDL cholesterol and triglyceride levels, even if we will take after food, there is no much interactions with the food also. So this fasting lipid profile, instead of taking fasting lipid profile, we can take the lipid profile even after taking breakfast or after food, and it will be a better estimation of the triglyceride level for cardiovascular risk and assessment. So now we can take postprandial or the after food, we can take the fasting lipid level for the accurate measurement of the non-HDL cholesterol as well as the lipid cholesterol.
Yes, I think I agree. This has been clarified by different guidelines.
Yes.
Postprandial lipid level also is very important and can be, especially as far as the triglyceride is concerned. So, any other question you want to comment, Panchanan?
Sir, taking venous blood and capillary blood by finger puncture, sometimes they estimate the lipid profile. What is the difference between a venous sample and a capillary by pricking the finger? We take the lipid profile.
Yes, Dr. Jana, is there an answer to that? Venous sample and capillary sample.
Sir, the venous venous values of the lipid profile is, I think, a little bit in lower side than the capillary. I don't know exactly, sir.
I also don't know. I think the routine is venous blood. Why should you go for a capillary blood as far as the lipid is concerned? And you may not get a proper samples to get the
Can I ask a question, sir?
Yes, yes.
How we can collect this capillary blood for this study? I don't know.
I also don't know. Panchanan might have read
with single. Sir, currently there are devices which take blood from capillary sample and they also give lipid values. But so far as I know, all the current prevailing guidelines, so far as ESCA and American guidelines, the recommendation is for venous sample collection. But lipid profile parameters can be given by n number of gadgets which have come up, which take blood from capillaries.
Capillaries usually for the sugar they use. I don't know about lipids.
It's a multi-value parameter. In fact, a boy from Bhubaneswar has come up with one of the devices of coming out with 5 different parameters, one of which is lipid profile.
That also needs standardized.
Yes.
So the problem is it is not standardized, but the problem is not that lipid profile cannot be estimated from the capillary level. It can be very well estimated.
Yes. In
so the guidelines say it has to be a venous sample.
Yeah.
Okay. I think we should end here. But what I want to comment, Dr. Jana, that at this stage, in fact, LDL is the only ApoB component which should be addressed as far as SCBD is concerned. That is there, that has been recommended, and in fact, long back I had reviewed the topic and given a talk in the CSI meeting also. The answer was LDL. Yes. But now there are still doubts, intermittently doubts arise, whether it is LDL cholesterol or some other component like remnant cholesterol or triglyceride or combined. They should be addressed or not. In fact, recently there were 2 publications, articles, one from Spanish study, second is from Copenhagen. The conclusion was that it is not the LDL which is important. It is remnant cholesterol and then VLDL or triglyceride. They have to be given importance in par with LDL, maybe more than that. But then there are editorials combining both the studies, which gave a conclusion that this should be a wrong message at this stage to the physicians and cardiologists. So we stick to LDL, not other components like remnant cholesterol. So we will have to address that. So I think with that we should go to the next topic, that is statins in primary and secondary prevention by Dr. Chabi Satpathy, who needs no introduction.
Sir,
actually,
Dr. Chabi is not there because of some problem that will be presented by Dr. B.R. Mishra.
Yes.
Okay, then we'll go ahead, please. Dr. Mishra will be presenting that topic. In fact, yesterday he was presenting the same thing So it will be very convenient for him. Dr. Mishra, please.
So, so I'll be a proxy speaker for Dr. Satpathy. So, am I audible and visible? My slide?
Yeah, visual and audible.
Yes. So, statins in primary and secondary prevention. So we know the atherosclerotic cardiovascular disease comprise of ACS, CCS, intervention, CABG, including peripheral arterial disease and abdominal aortic aneurysm. The prevention of ASCVD, the primary prevention is the measures to prevent or delay the onset of ASCVD. He has not suffered from ASCVD, but we can prevent it. Secondary prevention is a patient who has already suffered from ASCVD. We have to delay the onset of disease consequences or prevent the consequences. The LDL we know is the culprit. Although the different chylomicrons, triglycerides, they are called LDL remains primary target. So all these trials have shown reducing LDL plays an important role in primary prevention as well as secondary prevention. And where should we give statins? So you have to estimate the risk. There are several risk calculators like the ASCVD risk calculator used in the USA, where you take into account the gender, age, race, cholesterol, HDL levels, blood pressure, diabetes, smoker, etc. And similar risk is available, calculator available in Europe, the score calculator. And so you have to determine what is the risk from the in Indian the Lipid Association has given a risk stratification from the conventional risk factor, from the other high risk picture, which includes diabetes, CKD, familial hypercholesterolemia, extreme of single factor calcium scores, and carotid plaques and lipoprotein little a also. So they are low risk, moderate risk, high risk, very high risk, and extreme high risk. So up to high risk, the reduction of event is called a primary prevention because they have not suffered ASCVD yet. But very high risk, they are pre-existing ASCVD. So these are secondary prevention. And these risk categories are almost same as the European and American guidelines, but they have added one extreme risk in Indian guideline. Those with having coronary artery disease with a high risk group or who have recurrent ACS. So where we will give a statin for prevention? In any patient, LDL or more, right away give statin. Need not think or need not calculate other risk factors. And anybody who is suffering from ASCVD, you have to give statin for secondary prevention. Statin is one of the components, the major component for secondary prevention. And most patients with diabetes and CKD who has not suffered from ASCVD, they also require statin because of their high risk groups. So these are the groups where statin is recommended in children if there is their familial hypercholesterolemia, in young adults if their cholesterol is more than 160 and they have a history of premature ASCVD in the family, and young adults and older adults, as we see in our routine, between 70 to 189. If the diabetic or the risk factor, you give statins. And high intensity statin, you reduce less than 50% of the baseline, that is the value before treatment, or between 30 to 50 is moderate and less than 30 is low intensity. And what we use, atorvastatin, rosuvastatin, those are quite effective. Other statins, low intensity statins are not used in our practice. So these are the primary prevention guidelines by the American College of Cardiology. Look, they have risk stratified patients according to risk scores and low, borderline, intermediate, and high risk. And you can see all this, the risk, they end with statin therapy and statin therapy. So statin therapy is the mainstay, but while giving statin therapy, we should not forget that the lifestyle modification is one of the important steps in prevention that should go along with the statin therapy. And in this primary prevention guideline in 2019, they have given importance to calcium scoring coronary arterial calcium score in moderate intermediate risk person. In intermediate risk person, you can further risk satisfied with the calcium scores. If one less than with 0, they need not require statin or aspirin, but unless they have other risk factors. And 1 to 99 statin, 100 plus statin. So calcium score is gaining importance in primary prevention. Again, secondary prevention is less than 75, more than 75. All these groups you can see statin, statin, and statin. So statin is the mainstay of treatment of the primary prevention or secondary prevention. Now, what is the treatment target goals? Dr. Manavanjan has already talked about it. But the important to see that the target is decreasing. Now it is in the highest risk group is 55. With previous guideline it was 70. So LDL target is decreasing nowadays. So all the trials have shown that you decrease the LDL, you have more benefits. Same thing is in this slide also. So rosuvastatin, atorvastatin these are the two statins who have the highest efficacy of reducing statin compared to other statins. And these are the trials, the galaxy trials named after the names like Interstellar, AP, Meteor, Asteroid, Jupiter. All these trials have shown if you treat a patient with statin, both for primary and Indians are different already talked by Dr. Dana, and the mortality is decreasing in US and other developed countries, but it is increasing in India. So the Indian guideline I have already shown this risk stratification, but the LDL goals, you see they are in very high risk. They have reduced to 50. It is 55 in the European ESC guideline, but it is 50 in Indian guidelines. And the category B, the recurrent ACS, the guideline, they have recommended less than 30. So the LDL level target is decreasing further. Now there are some adverse reaction of statin like muscle symptoms, increased liver enzymes, new onset diabetes, drug interaction, but liver enzymes are not increase is not very clinically significant unless the patient have advanced liver disease. New onset diabetes, there are some reports, but the benefit of statin is so overwhelming that this minor risk is not considered, and there may be some drug interaction because the cytochrome in the liver. So there are reaction anti-clobell, maybe with antifungal, rifampicin, like or antihistamines. So they are possible that should be considered. And giving the statin attributed muscle symptom, it is a practical thing. There's a table as given in the guidelines. So if you measure if there is a myalgia, you measure the CK. If it is more than 10, discontinue. If it is between less than 4, it is okay. Between 4 to 10, you should stop statin for 2 to 4 or 6 weeks for a washout period. Then start with low dose statin, or there is some recommendation to give twice weekly alternative. So there are some steps has been given in the guidelines how to deal with statin associated muscle symptoms. So thank you for giving me the opportunity.
Dr. Mishra.
Yes, sir.
What is the incidence of diabetes in statin therapy?
There are some reports of increased incidence, but the incidence is so low and the benefit is so much that all guidelines said they do not bother about the new onset of diabetes. So you have to give statin as indicated, whether the incidence of diabetes increases or not.
No, as I understand, about 2.5% of people who are taking statins might get diabetes. This has been very well publicized by Dr. B.M. Hegde. Every year we are adding 250,000 diabetics because of statin therapy.
Sir, that Dr. B.M. Hegde's, sir, sorry to interrupt, but Dr. B.M. Hegde's data is not based on cumulative incidence of new onset of diabetes in all patients who are given statins. That is a data which has been specifically taken from Jupiter's study, where in low risk subset of patients, they were given a very high dose of statin for primary prevention. That was rosuvastatin at a dose of 20 milligram, and the incidence of new onset of diabetes has been recorded on the higher side of 2%. So we cannot say that the overall incidence, no.
Dr. Mishra,
Yes, sir.
Nowadays we are finding very young patients below 18 or 20 with significant dyslipidemias. Do you have any guidelines for them? At what level we should start treating? What drugs should we treat?
Guidelines say you estimate the risk. Like if the patient has a family history of premature SCVD and his cholesterol is high, more
I
than
agree with you. Family history. Nowadays, without this family history, with the newer guys coming and new urbanization and new fast foods. Nowadays, under 20, many patients we are getting it.
Yes, yes.
So, do we have any guidelines at what level should we treat?
I don't know the exact levels.
Because I think the level should be much lower than what you have said.
The
SEC, the normal values.
Sir, the SEC guidelines are the recommendation of starting at the earliest stage of 9 years.
Yes, sir. Please highlight. Deepak, please highlight. At what level should we?
The SEC guidelines, the SEC AHA cholesterol guidelines, which came out in 2018, have the earliest age of initiation of statin therapy as 9 years.
No. What I was trying to say, what was the blood levels, lipid levels in like triglyceride, lipid, and LDL? At what level should we start treating them?
No, the lipid
same as the adults or
yes,
lower value?
they have a separate lipid level for children and adolescents, and that I'm going to say in my presentation.
Oh, good,
and
good.
for that,
I'll wait.
Okay.
Thank you, Dr. Vishnu.
Rudando is there here? Rudando?
Yes,
yes, I am there. I'm listening. Sir, I am listening. Please go ahead.
And then you want to comment?
No, there is nothing to comment.
Sir, can you highlight anything about statin intolerance?
It is there.
Yeah.
And the one word of yes, Biswa, you finish. I'll tell.
No, sir, you can say.
One word of caution, which I have felt in 35 years plus clinical practice, because all of us are practicing high intensity statin now, especially following coronary intervention. Everybody gives the highest dose, either 80 milligram atorvastatin or 40 milligram of rosuvastatin. But a word of caution, you should be very careful, even if the side effect is very, very low. But it happens, and sometimes it may be catastrophic. I have one such patient which I think I have shared my experience in many platforms in our CSI a couple of times. So that has to be kept in mind. And unless you keep it in mind, you may probably miss the side effects, and that will be really catastrophic if you miss it. The patient that I am referring to, I have told it a couple of times, so I think most of the people here must have heard it. So that was a lady where I have done angioplasty. Then in the 15 days follow-up, she came up, she was telling that I am not feeling well. I am not at all feeling well. And then I did a ECG, ECG was normal. I did an echo, it was normal. I did everything. Then I was thinking, what is wrong? So I asked to do a, just like that. She was telling, I am just not feeling well. I have a lot of complaints. She was not able to tell what exactly the complaints are, but she's feeling I am very unwell. And looking at her, she was looking so sick. Then I did her urea creatinine and creatinine kinase. You will be surprised, the urea was elevated, creatinine was elevated, and CK was in thousands. So I immediately contacted the nephrologist there, and he told, sir, we have stopped statin. Even if you have done an angioplasty, it's a statin toxicity. It's not statin side effect. It was statin toxicity. He had muscle necrosis, and that led to acute renal shutdown. And we stopped statin. Everything reversed, and she is fine. Then, because her cholesterol was very high, next I was thinking, I searched the literature and I consulted a couple of people. So what should I do? Then they told you can try with ezetimibe. But ezetimibe alone is not very effective unless you combine with statin. So and then you can change statin to some other statin. That also I was not very sure whether I should give atorvastatin 80 milligram or not. Finally, I convinced the lady. She was on PCSK9 inhibitor. I have tried to bring down the cost, of what you tell, because if you buy it from the pharmacy, it was very expensive. I have convinced the people, the Dr. Reddy, and they have given at the cost of the wholesale, and she is receiving PCSK9 inhibitor. So this is a small single experience of mine in 35 to 40 years of cardiology practice. So one has to keep in mind when you give high intensity statin. It may happen once in your lifetime, but it happens.
Sir, muscle necrosis or muscle pain also she complained?
She did not. She was not specific.
Only I am not well.
Muscle pain, I would have just thought of that. She is told I am not feeling. For 15 days I was all right. After 15 days, she came and she told that I am not feeling at all. I don't have appetite. I am feeling lethargy. I am weak. I am not feeling well. She never complained typical muscle pain.
Sir. So,
Dr. Mishra, one good thing is that
yes, sir.
High lipoprotein LDL is reversible. So in that case, atherosclerotic really is reversible. I have told you this story before. There was a British nutritionist who got disease, strongly positive EMT, and he after angio, he was recommended CABG, but he waited and took his diet. After 5 years, he died of cancer, and they requested the coroner to do a postmortem. And he writes, these are the cleanest coronary arteries I have ever seen. So that is a good thing that if we take intervention, it is reversible.
Right.
Thank you, Professor Das, for the experience, the comment, and Professor Mishra also. But I have two things to say. One is that issue of diabetes related to the anti-cholesterol agents. In fact, that issue was there long back, and now even with PCSK9 inhibitor, that issue was raised, including cancer also in these patients. So it is now decided that there is nothing to do with statin or PCSK9 inhibitors. If you take 1,000 patients, give them statin for 500 patients, you give statin for 10 years, another 500 don't give statin. You will see that the diabetes will develop. These patients will develop diabetes in the long run. But may not, it's not, basically there is no relation between statin and diabetes.
No, has anybody answered the question, how long you take statins?
No, statin, now it is now decided that statin, if you are giving statin, especially high dose statin, you will have to continue. The down titration should not be done. It is dangerous if you down titrate, if you reduce the dose or stop the drug. It is very dangerous. You should not do it, and it has to be continued. The second question I wanted to ask Professor H.N. Mishra.
One comment before you ask me question. Sir, in a high risk or very high risk, you are supposed to continue, or you are doing a multi-vessel stenting, bifurcation stenting, left main stenting. But if it is a moderate risk or low risk, I think you have still a scope of down titrating. Once you achieve the goal.
But then you will have to monitor the patients.
Yes.
Monitor the patients.
Actually, very high risk and high risk, you need not down titrate.
Sir, যদি established CAD ହେଇଗଲା sir ତ very high risk ହେଇଗଲା na sir.
No,
there have been so many web meetings, and again, this is the opinion of in all these meetings that down titration should not be done, and if you are doing it, you will have to be very careful. Sir, and my question is, I want to ask, you see, in post ACS or post PCI patient, if you are given an option, should you give atorvastatin or rosuvastatin? This question is asked everywhere. So, but you see, what I want to say is that, yeah.
Sir, I would prefer to give, and I am preferring also till today to give atorvastatin 80 milligram because the data is robust about atorvastatin in post-PCI patients than in rosuvastatin.
Yes, I agree with that. That there are 1,000 trials, especially those post-ACS patients. So many trials are there involving atorvastatin. So, in a patient who has ACS or post-PCI patient, it is always recommended that, not recommended exactly, you should give atorvastatin. But I don't know what is the practice. 80% patients receive atorvastatin, rest 20 or 70% receive atorvastatin and 30% receive rosuvastatin. I don't know whether we should
myalgia is a problem with atorvastatin, which is not there mostly in rosuvastatin.
No.
ସେମିତି ନାହିଁ
it is individual, sir. Both statins can cause myalgia. You never know.
Yes, sir. Sir, ଯାହା କହିଲେ data is robust with atorvastatin. Primary prevention data is robust with rosuvastatin.
No, there are only few trials with rosuvastatin, but atorvastatin is there. There are so many trials from 2000 or I can say 1995 onwards. In fact, at one time I had reviewed all the statin trials.
Sir, everybody. Sir, everybody knows that. Everybody knows that, but somehow they are writing rosuvastatin. But if you ask them, they will tell atorvastatin.
Atorvastatin, yes.
Yes.
So next, if there are any no other comment.
No, sir. Whatever, see, even if whatever patients I have done PCI, rosuvastatin is used for cholesterol lowering in any patient. But post PCI, I have given always atorvastatin. So also, I think Dr. Behra.
Sir, I have also. Because
some cardiologists give. That is different. They can give, but then in our practice we give atorvastatin.
Sir. Most of the cardiologists they give atorvastatin, no doubt.
If there are no comments from panelists, is there any other comment? Dr. Samal, Dr. N.K. Mishra, Dr. Mohanty,
Dr.
Nirmal Mohanty.
Sir, one point about the diabetes incidence, we had a discussion elsewhere that the incidence could be because of fetal programming. So that when incidence initially came with statin therapy, they saw that it is even if a cohort of people was not given statin, similar incidence of diabetes was there. So one cannot attribute always that it is because of the use of statins. It's a small study, but it has already been studied. So this is about that. About
just been made the captain of the school.
Yes.
Which is the
about the incidence of these side effects, as Dr. H.N. Mishra has told, is a very, very rare incidence. As per the all the authors on statins, they say. I think Vishu has also reviewed an article with me on the statins. The incidence of the side effects are very rare. Mild myalgia is common, but initially if the people tolerate and you initially lower the dose, then gradually upgrade it or change the statin from one to the other, that vanishes in course of time. But statin as such is a wonderful drug in reversing total process of atherosclerosis. I think that's my comment.
Okay.
Sir, regarding diabetes, what you told, that is actually, it has been reviewed. Many trials shows, of course, a Jupiter trial first time showed that the chances of development of new onset diabetes is more. Some other trials also show, most of the trials are neutral in this aspect, but review shows the benefit is more than the harm.
That's always there.
Yes.
About the genesis, they told it is a fetal programming. Even if you don't give anything to them, they will come up with diabetes and dyslipidemia in course of time. That is already a study is there. So we had an impression initially that the statin was doing or inducing this type of diabetes in 2.5%, as Hegde was telling, giving that data. I think Deepak is possibly going to speak something.
What you are telling, that is causal relationship.
Yes, causal relationship.
But I don't think it has been proved because only this. real world data shows chances of development of diabetes is more.
Yes, there is no causality association.
I think we'll sir go to the next topic.
We'll go to the next topic. That is this is an interesting topic. Non-statin drugs in lipid lowering. What are the evidence? Dr. P.K. Sahu, please.
Good evening, sir.
Prashant, acha kichi kohuna
acha. Let me share my screen.
काम थिला तो मुगल तार आगे कोन ठीक है
प्रशांत मास्टर इन लिपिड
हां मुझे किछि कहनी पीसीएस के नहीं तो चलला किछि कहनी
चुप बच
दाढ़ी मारी रखी मोदी है कि चुपचाप बच्चे हो
Good evening, seniors and my teachers and colleagues. In fact, I have been given a very out of turn topic to speak on non-statin drugs in lipid lowering. What are the evidences? So if you have to see the so are these slides visible, sir?
Yes.
All right, thank you. So we always keep fighting about how to decrease the LDL, how to raise the HDL. So this is what we ultimately think about for the heart. But if you try to see what are these from statins when you jump to non-statins, this is what I could think of. Ezetimibe, PCSK9 inhibitors, bempedoic acid, fibrates, niacin, omega-3 fatty acids. Now, among these, only these three are of newer importance because these are, again, ezetimibe is coming up in a big way. PCSK9 has come up in a big way, and bempedoic acid trials has been done so that possibly the future will see this molecule being used more and more. I'll discuss mainly on these three molecules, and others I'll not discuss because these are all old trials that have been done. Now, when do we consider a non-statin? Basically, firstly, when the goals are not reached, or secondly, if the patient has a drug intolerance. These are the two situations when we think that we have to give a non-statin. Now, as we have been discussing till now, how low is safe? This is a review which I have been giving from 2021 journal of ESC, the European Heart Journal, that up to less than 30 milligram per deciliter LDL cholesterol is safe. This is what we call as ultra low LDL, and this is what we have to achieve in the very high risk patients. Now, if you try to see from 1994 to 2026, what you can see the till 2008 or 2010, most of the trials were on statins. Then around 2008, the ezetimibe trial started coming up, and people got more interested in this ezetimibe because statins were not doing the job totally. Then came the PCSK9 trials from 2017 onwards, Aspire, Fourier, Odyssey, and the Orion. And now in 2022, we'll be having the bempedoic acid trials, which will also be there. So I'll be focusing mainly on the ezetimibe and the PCSK9 inhibitors. Now, coming first to ezetimibe, we know that basically ezetimibe helps in decreasing the absorption of cholesterol, ultimately uptitrating the LDL level, receptors, finally decreasing the LDL levels by almost 25%, 15 to 25%. Now, if you see the 2019 guidelines, it clearly states that if the goals are not achieved with maximum tolerated dose of the statin, we have to think of combining ezetimibe. So here it is very clear that you have to only combine ezetimibe if your goals are not achieved with the maximum tolerated dose, and this is a class 1B indication. Now we are very aware of this slide that it is almost like jumping 3 times. Instead of doing a 3 titration of statins, if you just do add this ezetimibe, it is 1 step co-administration, and there is almost 18 to 20% reduction in the LDL if you add statin along with ezetimibe. This was the improved IT study which showed that clearly the mean percentage of change in LDL levels in all ezetimibe rosuvastatin combination was more than 50%. So this gave us the confidence that possibly ezetimibe is a drug which is resurging, and we have more data on it. Now, how ezetimibe acts is not only by LDL reduction, it has got antioxidants, does steroid reduction, this VSMC proliferation inhibition, and this the cell reduction is also there. Cholesterol crystal reduction is there. Now, it's very important that there's always got to be combined with the statin. You cannot give ezetimibe alone, as I was mentioning previously. Now, coming to the PCSK9 inhibitor, we know that PCSK9 inhibitor is one of the new kids on the block. This is basically a pro-protein convertase subtilisin kexin type P9 inhibitor. This is secreted by the liver and binds the LDL receptor on the surface of the hepatocyte, and basically targets the LDL receptor for degradation. Now, this is what happens. Once the LDL is taking PCSK binds to this LDL receptors, and ultimately it does not let the LDL work, and the recycling does not take place. So it's a very important mechanism of action that it works on the LDL receptors. This is normally what happens in the LDL receptors, that is the recycling of the LDL receptor takes place to clear from the plasma. And this is, as I've shown, I just share one example of this, which you can see this young boy of 14 years, where really there is an indication of LDL receptors, and Professor Mishra has also certain cases of this type, which has been sharing with us. You can see the big, this thing that is tendinous, this thing agents. And here you see when this patient of 14 years presented the anterior MI, and you could see a tight ostial left main stenosis. We did an angioplasty, and of course, were done guided by IVUS. And what we found basically, his lipids, if you see, the cholesterol was 466, the LDL was 371. So these are the cases of familial hyperlipidemia where, in addition to statins, you directly think of PCSK9 inhibitors. You cannot think that you can give the maximum dose of statins and finally wait that some miracle will happen. So the treatment was always the maximum dose of statins along with the PCSK9 inhibitor. Now, if you see, this is the publication of May 2021, where the European Society Task Force has clearly stated that you have to add a PCSK9 inhibitor in patients for primary prevention of adult patients with familial hypercholesterolemia. Then, when to use, targets are not reached with high dose statins, high risk or complex PCI. This is something upcoming that in ACS patients, you have to give PCSK9 inhibitor. We have enough trials in this area. And lastly, as I mentioned, the case of familial hypercholesterolemia. Now, PCSK9, as per the 2018 guidelines, it was to be considered to be added to STMB when a maximum dose of statin has been added. That means you have to add statin and STMB in the maximum dose. Then only you consider PCSK9 as a class 1 indication. Or if you feel that the LDL is more than 70, you have to think of PCSK9 reasonable and the patient is statin intolerant. Now, then comes the new area where it has to be used, that is in acute coronary syndrome. It was clearly stated in newer trials which were published in 2020 that it showed that the Odyssey outcome trial showed that alirocumab was expected to provide further insights in the fact that how PCSK9 inhibitor could work. Now, let us see what happens when a patient has an ACS. When a patient has an ACS, the PCSK9 level starts increasing and the maximum level is at 24 hours. This is how it occurs. Now, if the PCSK9 levels are maximum at 24 hours, you have to get this PCSK9 level as early as possible. And the best way to do it is by giving a PCSK9 inhibitor. And if you give a PCSK9 inhibitor, you can get these levels down to whatever level you want. Now, this is what happens when there is an increase in the PCSK9 levels. Basically, there is a destabilization of the coronary plaque. And once there is a destabilization of the coronary plaque, and this is an independent predictor of coronary artery disease. So if you administer PCSK9 inhibitors in ACS situation, possibly you have enough data now to show that this stabilizes the plaque and the further recurrence of events are decreased. Now, the Odyssey trial was published or presented in ACC 2018, where they showed that almost a 54.7% reduction was there at 48 months. This was with alirocumab, and it was seen that after 1 year, the major adverse cardiac events did diversify. So this is something very important for alirocumab was given, and this was all in ACS patients. So Odyssey was in ACS patients, and almost more than 24% of the patients received the maximum dose of statins. Now the 4-year trial came, which was in chronic patients. It was seen that the LDL could be reduced by 59%, also decreased the cardiovascular outcomes in patients already on statin therapy, and it was found to be safe and well tolerated. So it was seen that almost within 24 weeks compared to placebo, there was a significant reduction in the levels of LDL. Now, the LDL reduction was by 59%, decrease in cardiovascular outcomes, and most importantly, higher the risk, higher was the benefit. High risk reduction, especially multivessels, prior MI, and better results in diabetics patient and with peripheral artery disease, and was considered to be safe and well tolerated. Now, then come all the trials on ACS, EVOPAX, OCT trial, EVAX, IVUS vascular histology, and the NMR study. This all came in 2019 to January 2021. And we have the data. The EVOPAX decreases the LDL by 40.7%, which reaches the goal. Almost 95% patients reach the ACC goal, 90% reach the ESC goal. And if you see the EVAC study, the EVAC study showed that at day 4 to 7, the LDL was almost reduced by 59.6% compared to placebo. And this was also shown that the evolocumab initiated in the hospital early after ACS rapidly and significantly reduces LDL in just 24 hours. This is theoretically true because we know that the PCSK9 levels are highest at 24 hours. And the guideline just recommended that LDL targets applicable to ACS can be achieved when most patients at hospital discharge are still present at 30 days. So if you give one injection of PCSK9 at the time of ACS, there is every likelihood that this patient maintains a low PCSK level at day 30 also. Something more interesting is here is that if you give evolocumab with statin, there is a reduction of the small LDL by 67.3% compared to only statin. And most importantly, you see in ACS who received statins, the LPA levels were increased by 82%, and evolocumab had the property of decreasing the LPA levels, which was not seen with any of the other drugs, non-statin drugs. Now, let us learn from some imaging studies. The Atherma-IVO study clearly showed that the endpoint of death in ACS was independent of the serum LDL levels, and PCSK9 levels were also directly related to the lipid core burden. Now, the OCT trial clearly stated that if you start evolocumab early, there was not only a decrease in the thickness of the fibrous cap, increase in the thickness of the fibrous cap, but also the lipid arc also decreased. This was a 12-week follow-up made from the OCT studies, which showed that if we can stabilize the plaque, there is more chances that these patients can be managed medically rather than putting them onto any intervention. These are especially for intermediate lesions where we did not have to do any intervention. Then the NEEDS-IVO study was a very small study, which also stated that lipid core burden index could be decreased if you can give the PCSK9 inhibitors early. Now, the most important thing which I had highlighted earlier, higher is the risk, maximum is the benefit if you give the PCSK9 inhibitor, and this was seen that as the risk increases, the LDL was the relative risk reduction was lowest in those patients who had the highest risk. That is multivessel disease, high risk interventions, diabetes, all these patients were considered. Now then from the concept that how low to go in ACS, so it was said that if PCSK9 inhibitors could enable most patients with ACS to achieve LDL levels less than 30 to 50 and was shown to superior in the prevention of recurrent cardiovascular events. This was compared to the statins, and it was seen that if this was given in ACS, possibly the results would be excellent. Now, if you see complex PCI, you see CABG, you see complex revascularization, and all these arms, you see the Forrester graph, what was published in 2021 recently, that they all benefited with evolocumab as the risk went on to be very high. Now then came the inclisiran, which was the Sirna. This was basically the small RNA which was targeted, which decreases the PCSK9 production, and inclisiran is already available in UK. In fact, the trials have been started, and we are one of the centers who have been enrolled for the inclisiran trial. And this, the beauty of this injection is that you have to give a 6-monthly injection, and this will be a trial to be done for 5 years to see what is the role of PCSK9 inhibition in post-intervention patients. Now, there have been a various series of trials starting from Orion till Orion 11, and they have shown that there is almost 51.3% reduction in LDL to all, and some studies to almost 45.8% reduction in the inclisiran. And this was maintained. The beauty of this was maintained, and this made the UK government, the National Health scheme, give them free inclisirans to patients for in London for the patients who underwent interventions. Now, if you try to see all the PCSK9 inhibitors, you see that the Odyssey long-term trials have been already come up. It has shown that they can reduce the major adverse cardiac events, and this reduction was definitely very significant, leading to ultimately good outcome in the long run. Lastly, the bempedoic acid, we have very little experience. We have literally no experience. It was clearly shown that bempedoic acid cannot be given in alone. We have to wait for the large trials to come, but they were given in combination with atorvastatin and HTBB for patients who could not tolerate it. And this was what was seen, that they could almost 63% reduction of LDL could be achieved at the end of 4 weeks. Now, what were the guidelines? The guidelines which came up in May 2021 at the European Atherosclerosis Society clearly stated that if the patient is intolerant to statin, you have to consider HTMB with or without bempedoic acid. And if the patient is in step 2, if you're on high statins, not reaching the LDLs, give HTMB or add an PCSK9 inhibitor, especially in the high-risk patient of polyvascular disease, post-CABG, diabetes, LPA very high, and familial hypercholesterolemia. Because this is the only agent which has been shown to reduce LPA. Now, we know that if you go on adding multiple drugs, possibly a PCSK9 inhibitor plus high-intensity statin can decrease your LDL by 85%. This was the maximum that one could achieve by adding various drugs and coming to the results. Now, if you see the last 25 years of LDL, all the trials came about this thing that is statins. Then people started thinking that not lower is better, even lower is even better. That came with the improved IT study. Then the 4-year and OD study gave us the data that lowest is the best. So to cut the things short, that it was from statins we started. Now we are going into non-statin drugs to make a combination so that we can know that the lowest is best. And the last article I showed in the European Heart Journal that less than 30 is also very safe. Now, to make a long story short, non-statins in decreasing LDL are HTMP, PCSK9 inhibitors, and bempedoic acid. They can achieve ultra low LDL, and this has been proved to be safe, but one has to have a word of caution that one has to be very careful in following them up. If the patient is already on statin and HTMP, most of our patients do get the benefit of decreasing the LDL levels. If they do not, the high-risk patients, you have to start PCSK9 inhibitors. With the statin intolerance, you can combine HTMP with bempedoic acid. PCSK9 given earliest beneficial in ACS patients, this has been shown, and the emerging therapy is inclisiran, which possibly will see new data as we go on. So as I said, do not wait to strike till the iron is hot, but make it hot by striking hard. Thank you very much for the patient hearing.
Thank you, Dr. Sahu, for phenomenal data. In fact, it is always a pleasure to listen to you. The data were excellent. The message is, I think, as far as your statement is concerned, is very clear. Any patient who is admitted with KCS or is planning to take him to PSLF, best thing is whenever you are giving a statin and other drugs, you will have to inject PCSK9 inhibitor. I think that is the message.
Coming up in that context, articles have already come up that when they taking up a PCI, you give one shot of this thing that is evolocumab also, along with statins.
And then, in fact, though the Odyssey trial was earlier, the eye openers were the Evopac and Evac trials. They showed the road. In fact, you can give the injection in SAS patients and you can get excellent results, long-term benefit. As far as the ILR, I mean, inclisiran is concerned, you have Orion 1 to Orion 11, 12, the results are out. But the most dedicated trial, Orion 4, which is dedicated, in fact, is addressing the CV outcomes. The result is will come out in 2026. Maybe after that, we will get an, some sort of guidelines. Anyway, any comment? Satya, you want to say something?
No, sir, it's okay. He has covered everything.
I have one query.
Yes,
sir.
Are you aware that any oral PCSK9 inhibitor is on pipeline?
No, sir, I am not aware.
And I have a question.
Yes.
The PCSK9 inhibitor, how you program for how many years? A young man is having this, or the patient you showed, having this primary familial dyslipidemia. How would you plan for a long life? What will be the cost effectiveness?
In familial hyperlipidemia, you might have to give it lifelong.
Right. So what will the expected cost? What is the dosage you plan?
See, now actually this drug is being imported from outside, and I think sir is very much aware. Professor Mishra is very much aware. He has certain patients who have been, he has sent to Delhi. The whole family has gone. In fact, this patient was of Dr. Dikshit, whose angioplasty I had done. In fact, this was a very surprising case, and we were surprised at how tight a left main stenosis this child had. So these patients, in fact, have to take a long time. Some trials have been done. by a group in Delhi. They're giving free injections if you enroll in that trial.
But in 3 injections, will the things clear for the lifelong?
No.
That's it. So you have to go on giving it repeatedly.
Yes.
Annual dosage or biannual dosage, and the cost is prohibitively high. At present, I think it is around 10 lakhs or something, $14,000.
It is around 15,000 rupees. But if you, as sir had told, if you buy directly from the supplier,
15,000,
12,000 or so. 15,000 rupees each injection.
Is it 12,000?
Yes.
I think Professor H.N.
It may be only for you, sir, but it's very costly for the patient.
No, Doctor.
It's 12,000 only.
Dr. S.S. Mishra, see, life is more costlier. I have seen premature coronary artery disease in familial dyslipidemia in a young girl. Severe triple basal coronary artery disease, nothing could be done, and she died at a very prime age. I have another patient from Talcher who has undergone CABG, and that fellow again I have convinced him. He is on PCSK9 inhibitor. He has xanthoma, as Dr. Sahu has shown. And once I convinced him, otherwise your life will be 2-3 years. There will be again restenosis and repeat CABG. You know how difficult it is.
Yes.
So yeah, once you convince them that life is more important. See, not for everybody, but somebody who can understand and appreciate that even if after a percutaneous revascularization or a CABG is going to have a severe restenosis with a very short period of time, and you have to give it, and you can convince the company when you give for a long term, there are some arrangements, the cost can be reduced, they are agreeable, still they are giving it, and that boy is taking. So it is not that you have to convince them.
No, what is the
So the story is like this, I will tell you.
Cost is how much? That is
Dr. Behra will agree. Dr. Behra will agree. When we started intervention, we were using bare metal stent because the bare metal stent was 30,000 or 50,000. The cost of the drug-eluting stent was 1,37,000 some paisa, and he was not reducing 1 rupee. So once you start convincing the patient, we were telling nobody will use this drug-eluting stent in Odisha. It is impossible.
Present, what is the cost? That is what
Dr. Behra will agree. We told them nobody will take. But then once you tell the advantages and the life, then there are people who will take it. So cost is prohibitive, but life is costlier than everything else.
I agree on that point, because if you do the proper counseling, at least.
Sir, this is correct. But what is the real the expenditure at present for a man who is agreeing to take? That is what we have.
Prashant କହିବ, Prashant ଗୋଟେ request କରିବି. Prashant, initially we have to give every 2 weeks. Then once it is controlled, what is the maintenance?
So normally what we do up to 6 injections we give every fortnightly. But we see most of the patients respond within 3 to 4 injections. The LDL comes down to almost 11, 10, 8, and some labs are telling that we are not recording LDL. That also we have seen 0. So this thing they give us a call that we are not able to record LDL. So what we do then, we try to down titrate, and possibly along with the maximum statins, we give it at 4 monthly, 3 monthly interval, so as to maintain the LDL less than 40.
If it is 3 monthly, 4 monthly interval, patient can easily afford 10,000. I think it is, though it is 15,000, the company is providing 10,000. They came just 15 days back here. They
If you for every 4 injections, they give 1 injection free. They give.
So maybe cost will be still less after some days.
Naturally, after some years.
Yes.
Only one thing that I have observed, almost more than 100 patients when I follow up of PCSK9, but I have seen that these patients, quite a significant number of patients are developing anemia. I have no idea why. There is a drop of hemoglobin almost by 2%. We are analyzing our data, and let us see. Because inclisiran is also coming. We have taken the phase 4 trial of inclisiran. Let us see how inclisiran works.
I have read there is a work going on. It's a phase 2 trial, oral PCSK9 inhibitors.
I'm not aware, sir.
Once it is available, it's not yet available. It's in the phase 2 trial. So once it becomes available or once it is approved, then I think that will be a game changer in the management of lipid.
That's a wonderful drug. That's correct.
My question to Dr. Sahu, just one question. You did not mention anything about the trials involving EPA, eicosapentaenoic acid, especially
Yes.
reducing trial.
There was a lot of hue and cry about EPA and all this thing that is fish oils.
Reduce and jellies trial.
Sir,
Jellies
but what
trial,
has happened is that if you review the recent literature, they have clearly stated it is of no use.
Agreed.
But then
So,
reduce.
But triglyceride it has a use.
ACCHA say that they have only food value. They have no therapeutic value.
So I didn't discuss them.
In high dose, they can,
this is
they
a
have been
wrong
shown
message.
to prevent sudden cardiac death in a very high dose.
EPA 4 gram has shown to reduce triglyceride and reduce mortality results incidence also. So these they have said the other things, those are available as food supplements and other drugs are not useful, but EPA 4 gram daily is useful. That is the literature.
In that dose only, not the
In
dose
that
available
dose,
in the
4 gram per day. 4 gram per day.
No,
EPA.
4 gram
The
per
mechanism most likely the preventing sudden cardiac death that will be addressed by Dr. Deepak.
Yes, Deepak will
Deepak.
address it.
Anyway, let us go to the next topic. Deepak, please. Non-HDL and TG, how important are they? I think we will have discussion on that. Deepak, please. Deepak, are you at Puri? Hello.
At Goa.
Are you at Puri or something?
No, sir. Background available. You can use it.
I thought you were at Puri sitting on the sea beach.
Background you can use also.
Okay.
Am I? Is my screen visible now?
Yes.
Visible and you are audible. No problem.
My revered teachers and all respected senior colleagues, I have been given a challenging issue to address, and it's already so late. But basically, I will try to highlight the controversies regarding this, because we know that LDL is obviously the
You are not audible.
Deepak has answered.
So, am I audible now?
Yes, sir.
So, when we think of non-HDL, we should have a bird's eye view of what are the different plasma lipoproteins. Now, at the rightmost corner is the HDL that we say as the protective LDL cholesterol, and in the lower end is the VLDL, and intermediate we have IDL, LDL, lipoprotein little a, and the key molecule is LDL cholesterol, which has been highlighted by all my previous speakers. In fact, a part of my topic has already been discussed by the first speaker itself. But when we think of non-HDL cholesterol, it's basically ruling out protective cholesterol and encompassing all harmful cholesterol and atherogenic triglyceride-rich lipoproteins, that is atherogenic. And we know that the South Asians have an atherogenic dyslipidemia. And when we think of dyslipidemia in Indian settings, Dr. Rajiv Gupta is a pioneer worker, and his latest data came out in 2017. And when we think of most common dyslipidemia, it is high triglycerides. So it's not what is important for the Caucasians like the Europeans or the Americans. We have to think in terms of what is important for Indians. And what has been really starting is studies have reported over a 20-year period. That means Dr. Gupta had a study which was conducted more than 20 years back, and he has subsequently come out after 20 years with data that triglyceride levels have increased among urban population. It's not that it was high, but what is startling is it's also increasing amongst urban population. And that's why amongst the different significant associations, they have also considered non-HDL cholesterol. So, and this is ICMR data, not Dr. Rajiv Gupta's data. And here, the prevalence of different lipid abnormalities, we find that hypertriglyceridemia is 29.5%. Of course, low HDL cholesterol is very high. That's because amongst the patient population, it has been selectively found out that the low HDL cholesterol is comparatively higher amongst female, and this subset of patients had a higher female subset of patients. Now, that the Indians are just raking up this sound about non-HDL cholesterol and triglycerides, or the other international guidelines. When people think of LDL cholesterol, then everybody cites the ACC/AHA guidelines, because ACC/AHA guidelines have unquestionably told that the LDL cholesterols are the optimal target, and there lies our controversy. But I will show the ACC/AHA guidelines which came out in 2018 that they still have recommendations about measurement of non-HDL cholesterol, and that is you must measure non-HDL cholesterol. I don't know if you don't give importance to non-HDL cholesterol, then why would you measure it? But we must not forget that this is a class 1 recommendation, and in adults who are 20 years or older, not on lipid lowering therapy that you have to do, and people who have higher triglyceride levels, that is say 400 milligram per deciliter. And for patients who have been given statins and they have LDL cholesterol level less than 70 milligram percent, there also you need to do assess a non-HDL cholesterol to improve the accuracy over the Friedewald formula, because we know that majority of laboratories do not actually evaluate all the 5 parameters in the lipid profile, but they in fact estimate the 3 parameters and then use the Friedewald formula. And in adults who are 20 years or older without a personal history of ASCVD, but with a family history of premature atherosclerotic cardiovascular disease, there also you need to measure non-HDL cholesterol. So, and this is very obvious because we know that Indians have the atherogenic triad, and amongst that, when the Lipid Association of India, they came out with the latest recommendation. So they come out with not just LDL cholesterol recommendation, but non-HDL goals as well. And that is why when they have mentioned about very high risk, moderate risk, low risk, everywhere, besides the LDL-C goal, they have also mentioned the non-HDL cholesterol goal. And just to simplify it, you just add 30 milligram per deciliter. Whichever is the target, you can add 30 milligram per deciliter to reach the value of non-HDL cholesterol. And if we actually think of the statins have been the superstars for treating dyslipidemia, but there have been so many trials amongst the different meta-analysis of statin-related trials. Voyager meta-analysis is considered to be one of the landmark meta-analysis which is being discussed in all lipid forums. But if you see the real the data analysis of the Voyager meta-analysis, you will find that they just don't give importance to LDL cholesterol, but simultaneously they also give equal importance to non-HDL cholesterol and triglycerides. So it's not that they are not important. So they are important. Maybe we don't know exactly what is the quantum of their importance. And one interesting finding as to the discussion which previously we are having from our teachers, which is the drug. Perhaps this is where rosuvastatin has showed higher reduction of non-HDL cholesterol as compared to atorvastatin. Now, this is an important slide. It must have been shown by every single every single speaker before me. So, but what is conveniently missed is when you go to very high risk of atherosclerotic cardiovascular disease, when you treat all these things, you don't just focus on LDL cholesterol, but here comes patients who are really troubling you and you are compelled to search for new drug options. There, assessing the non-HDL cholesterol becomes very important. And when you think of PCSK9, at least get a non-HDL cholesterol. Now, as to answer the query of Bajoria sir, in primary prevention in age groups, children and adolescents, the recommendation starts at 9 years. So that's the lowest age at which there is a recommendation. This is, of course, a class 2A recommendation. And here, besides fasting lipid profile, what is important? This addresses the queries of some of our previous participants, non-fasting, non-HDL cholesterol. So the non-HDL cholesterol needs to be non-fasting, and let us not forget, here there is nothing about postprandial. It can be any time. So unlike fasting and postprandial in blood sugar level, it's not that. So here also, this comes from ACCHA recommendation. So we can't say that these are not important. And as regards the values in childhood, this is from ACCHA. You have to calculate the cholesterol, the triglycerides from 0 to 9 years, and of course 10 to 19 years triglycerides needs an evaluation, and non-HDL cholesterol. So the values for children in the triglyceride values are less than 75 is acceptable. Borderline is 75 to 99. Abnormal is greater than 100. And for 10 to 19 years, the triglyceride value is less than 90. 90 to 129 is borderline. Greater than 130 is abnormal. And if you just think of non-HDL cholesterol, then it's less than 120, 120 to 144, and greater than 145. So there are, of course, certain values, but we don't use it. Maybe we don't estimate the lipid values. And why this concept of assessing? Because if LDL cholesterol was able to address to all our queries, then these things would have been just, they would have vanished. But the concept of residual risk means we know that atorvastatin has been a wonderful molecule. And one of the landmark study in any atorvastatin discussion is treating new targets as a TNT study. It was of atorvastatin, 80 milligram. Now, the relative risk reduction is 22%, highly significant p-value 0.001. But what is the extent of benefit is, in these patients, you still have a 78% residual risk. So whether addressing LDL is landmark study in any is giving adequate answer to all our queries or not, that is a matter of conjecture. Next, we come after non-HDL cholesterol, triglycerides. Then people will say that the ACCHA guidelines have been very categorical. And this is the matter of controversy, that if you have a triglyceride level which they consider high, that is 175 to 499, fasting or non-fasting triglycerides. And triglyceride levels are considered as a factor for favoring initiation or intensification of statin therapy. So between 175, 414, 499, you don't change your drug strategies. You still stick to statin, and you just do some lifestyle factor modification, secondary factors like diabetes mellitus, chronic liver disease, hypothyroidism. So you take care of these things. And when the only when the triglyceride level is greater than 500 mg/% or the SCVD risk is 7.5 millimeters and higher, then you have to address the reversible causes of high triglyceride and initiate statin therapy. So, and whenever you think of taking a statin, it is only after 500 milligram per deciliter of LDL cholesterol, and that too prevent acute pancreatitis. So people might be pushed into a sense of complacency that hypertriglyceridemia is not given due importance by the American guidelines. But if you see, this is the same guideline. The American Heart Association guideline mentions risk enhancing factors for primary prevention in non-diabetic patients. And non-diabetic patient, 40 to 70 of us is with a 10 years risk of 7.5 less than 20%. These are the risk factors and persistent elevation of triglycerides greater than 175 milligrams. So it's not very important. They're not important. If they are not important, why they will be considered as risk enhancing factors? And this is the most highlighting study which has actually separated the grain from the chaff. Now, this came out in 2018, conducted by Chapman et al. Now, this is the most beautiful picture that you can see. Relationship of non-fasting triglycerides. Remember, it is non-fasting triglycerides and risk of myocardial infarction, ischemic stroke, and total mortality. And when you look at all these things as different quartiles, as triglyceride goes on increasing, the events goes on increasing. So whether we have got an answer to this query is a separate question, but this is not a valid query that we can't say. And this, when you look at this analysis, looks quite jumbled, but what is most important is, if you somehow or the other, the elevated triglyceride and the low HDLC subgroup, this is most important because the Indian dyslipidemic triad or the atherogenic triads is clearly fitting into this elevated triglycerides and low HDLC cholesterol. And here is the real significance of the increase of events. So based on that, 2011, this came out in European Heart Journal. Chapman et al. Suggested a proposed algorithm of management of high-risk individuals with elevated triglycerides and low HDL cholesterol at LDL cholesterol goal. So even if you achieve LDL cholesterol goal, if you have low HDL and elevated triglyceride, you could be still high-risk individual. And here they have considered adding therapies which will actually intensify the reduction of triglycerides. So I will say this will be my important slides which we need to observe. These are two most important guidelines which have been assessed by every one of us. But unlike the American guidelines, treatment for high TG is only after 500 milligram per deciliter. That's why there is very little, many of the people are still lulled into a situation when they think that very rarely we'll see 500 milligram per deciliter. So basically we don't need to give importance to triglycerides. But if you consider the European Atherosclerotic Society and European Society combined guidelines, the statins and vibrate for triglyceride once it reaches 200 milligram percent. And if you ask yourself, amongst the so many lipid profile reports that you see every day how many people have triglycerides level greater than 200 milligram%? Definitely a substantial number of them do have. And that's why we just can't brush them aside. So the key take-home message will be non-HDL cholesterol and triglycerides are definite important considerations amongst Indians. I don't have sufficient data to tell about the Caucasians, but definitely among Indians, even if not more important than LDL cholesterol. And their importance gets augmented when dealing with high-risk primary prevention or secondary prevention. Thank you for your presentation.
Thank you, Deepak, for highlighting the importance of the two important components of lipid profile. Rudando, you are here. Rudando, achagi? Hello.
Yes.
Please take over. Mu ଟିକେ କାମ ଅଛି ଯାଉଛି ସତ୍ୟ.
Agia.
Rudando, rest of the program will be.
The deliberation is excellent, and I think the evidences are also absolutely well displayed by Deepak. That because see, all of us are swayed away by the European or American or the Western guidelines, and now there are enough data to support that the Indian dyslipidemia is not the same as the Westerns. We have a different phenotype, we have a different lipid profile, our coronaries are different, our disease profile is different. So what Deepak has told, see, this confusion or conflict is going on for a long time, whether triglycerides should be given importance or should not be given importance. And one group, like the Americans, we have heard an American, he gave a lecture in Swasti. I think most of you were present when we asked. He told it's only LDL cholesterol and LDL cholesterol and LDL cholesterol. So some of the audience, they stood up and asked about Indian type of dyslipidemia. Then he was not prepared to accept it because they were being only concentrating on what they were, whatever research or whatever work there is there from their own country. So I think my views completely endorse what Deepak has told, that non-HDL cholesterol and triglycerides has to be given. See, I don't say that the LDL cholesterol is not important. We must, that is the prime thing, and we have robust evidence in that favor. But as far as our patients and our practice is concerned, we have to give importance to non-HDL cholesterol and triglycerides. That is what, Satya, your view, and Dr. Bajoria, and others' view, let us hear.
Sir, actually, this is what we call diabetic dyslipidemia or Indian type of dyslipidemia. But in one analysis, they have shown world's 40% of the population live in this area where triglyceride is high. And if they take all the people with a higher TG level, almost 50% of the diabetic do have higher triglyceride level. They live in this area or in other area. And there are studies coming up from Europe that atherogenic direct triglyceride being directly atherogenic. Studies are coming up. They are coming up from European, mostly East Europeans. So we cannot ignore triglyceride. Triglyceride has to be given importance, particularly in our setup. And as Deepak told, almost more than 60 in that TNT trial, 70-80%, but most of the studies, more than 60% do have residual risk. When residual risk is there, again, you'll have to take non-HDL cholesterol, will have to take into consideration. So definitely, sir, non-HDL cholesterol and triglyceride particularly will have to address, and triglyceride particularly in Indian scenario, particularly in diabetic also.
Well, I suppose we need more studies on the Indian setup because our dietary habits, living standard, environments are quite different from the English or European or Americans. They are more urbanization. Though our cities are developing, still majority of the populations are in the villages. And if we see them, hardly we find dyslipidemias. But in urban population, even if we westernize, still we get, as everybody has said, more of triglyceride along with high LDLs. So what we need to study the dietary habits, environment, urbanization. Say dietary habit. We urban people take a lot of butter, which is hardly say 5 or 10% of the population. But still, majority they take a lot of ghee. And more so in North India. And how many village people are suffering from coronary artery disease? And I think that
village people also suffer from coronary artery disease. We have enough data from our registry. So that
percentage wise,
percentage wise also.
Huh?
It is no more true, because there is something called thrifty gene, and they are more diabetic. Their diabetes incidence is more. The coronary artery disease is also equal. So, sir, that urban-rural differentiation is narrowing down very much.
Narrowing down. Now they have picked up. Rural people,
so that concept 20 years ago that urban people were having more coronary artery disease, more diabetes is no more tenable, sir, in India.
And simply taking rice can give rise to higher triglyceride.
Yes,
rice eater.
That's the point.
They are getting urbanized, and even the cultivations, they are using more and more machineries. And now in villages also, they get more and more, even in kitchen, everything. They've got more machines and equipment than what they used to have. So I think the urbanization of the villages has their contribution. But I can say 15, 20 years back, yes, very, very limited number of coronary artery disease. It might have come up in last 2 decades. Anyway, I must thank you, the speakers. They've done an excellent job. And back to the panelists and the moderators.
About the one, I have one query because to Deepak. Deepak, can you hear?
Yes, sir.
Now, about the quantitative HDL estimation, there are now issues. It is the HDL. But the quantitative estimation, is it important than how low or how high? Or it is the, what you call the HDL quality or HDL property which is more important?
Sir, actually, I had a slide on,
HDL.
I had a slide on functionality of HDL.
Functional HDL.
The large buoyant HDL particles are not, in fact, may not be highly functional. So, but Sir has raised a very valid point, because if we find majority of lipid profiles, they utilize the Friedewald formula, and in Friedewald formula, one of the most important assessment parameter is HDL cholesterol. So, if your HDL cholesterol estimation is not exact or not appropriate, then the key thing for which you are utilizing Friedewald formula is to calculate the LDL cholesterol. The LDL cholesterol measurement gets distorted because of HDL, and it has been found the mostly completely automatic lipid profile analyzers have a sense of accuracy which can be considered. Otherwise, most of the semi-automatic and other methods of estimating, they have a variable range of estimates, and the exact methods which have been suggested, that a venous sample should be estimated for HDL cholesterol for 3 consecutive times when they show a variation within 2% error range. That should be a correct method, but I am not very sure how many laboratories will be doing it to exactly estimate the HDL cholesterol.
Any thoughts or talks about LDL particle size, Dr. Deepak?
Sir, the LDL particle size assessment has been done in research studies, but the general laboratories coming up with LDL particle size estimation are not very common. I have not yet seen any, say, Randaxi or big laboratories coming up with LDL particle size estimation, but they are done for studies, research studies. Yes.
So if there are no further questions, I think Dr. Rautrai can cover and give.
Yes, sir. So much discussion on every topic. I don't think so further take-home message is needed.
Okay.
So actually, not only that, we are also
And
already.
then,
Yes.
and
yes.
then also you are approaching 10 o'clock.
Oh, yes, 10 o'clock.
Dr. Samal didn't say anything.
Oh.
On
one line about familial hypocholesterol. My friend Dr. Singh, Kitu Singh is a pioneer.
Yes.
In doing series of familial hypocholesteremia. He told is a very underdiagnosed, undertreated DMOIT. So a person of say younger age group had LDL over 190 or so, pretty much had used suspected familial hypocholesteremia. He told you do some research at Odisha. I will support him. He is doing a research work at Gangaram Hospital, very pioneer and giving speech in all the conferences, very pioneer in that. So if somebody or someone else who start some research on familial hypercholesterol, it will be beneficial for us.
Sir, he is the person who is in that Lipid Association of India. He is doing that work in Gangaram Hospital, and whose patients we are also sending actually to the same Lipid Association of India taking care.
He told you what the classroom was in Odisha, I will support you.
Yes.
Class and class 2. We are not doing that.
And according to him, it is quite common. This is not that uncommon. Yes.
That is under-addressed because we don't do the lipid profile in young children. Because our pediatricians are not yet conscious.
Cascading family study.
Yes.
Everything has been shared in the meeting.
I think Bisu, yes.
Yes, sir. Yes, sir. We'll end.
Yes.
So the next CSI event will be our conference, just a month. So we'll be now we'll have the further same after our conference.
10 conference will be both 3 days, 10, 11 and 12th of September. 10, 11, and there are only a few participants now because actually I want to say something. I will post the one event that is CME undertaken by the cardiology department of SCP Medical College in the pre-platinum jubilee CME celebrated by the SCP Medical College. That I will circulate. I will request everybody to join.
Okay. Kebe sir? When?
Say that 20 Tarikh and Dr. McMurray, John McMurray and Dr. H.N. Mishra. They are 2 speakers.
The topic will be on heart failure management.
It will be followed by some dinner or
online.
No dinner.
Online.
Dinner Zomato dinner. Zomato dinner virtual.
Zomato dinner by Dr. H.N. Mishra.
Sir, 4 to 5 p.m. sir.
Sir, it will be delivered.
4 to 5 p.m. sir. Dinner how can they have?
It will be delivered on demand. Je demand kariye specially mo pa ola pathaibe mo pathaibi seta side.
Sir, virtual dinner pathai.
Professor H.N. Mishra is silent. He is not opening.
Sir, chhad dele ki.
नहीं सार इनवाइटेड स्पीकर आपण जदी डिमांड करिवे आमे दबु आमे सार को निमंत्रण करिछु सार कोन खायो देबे सार हम अतिथि आमे खायो आपण खाइले आमे खायो
because this is
most speakers are not yet prepared.
Okay, at the end
Sir, এই মাসের 28 না কোন?
এই মাসের 20 তারিখ
20 অগস্ট স্যার 4টা রু 5টা
Friday 4 to 5.
Okay. So at the end, I express my gratitude on behalf of CSI Odisha chapter to Professor J.P. Das for inaugurating, giving his address to us. And I express all my sincere thanks to our chairperson, Dr. S.S.L. Bajoria here, Professor H.N. Mishra, Professor Vera, Dr. Panchanan Sahu, and I thank the speakers. They did an excellent job. our young speaker Manavandan Jana. He did a very good job, and I encourage him for doing such activity in future. Prashant, I thank you, Prashant, from the core of my heart. There's some problem in timing, but you remain till the end. I'm very happy. And at last, I'll thank our moderator and our president, sir. And with the permission of the president, we will end the meeting.
Good night, everybody.
President sir, thank you.
President sir, namaskar.
President sir.
Sir, namaskar.
नमस्कार सर
सर भुवनेश्वर बाहर अछन
सर नमस्कार
अरे आपण कोठी अछंती
ମୁଁ ଟିକେ ବାହାରେ ଅଛି
होटल 5 स्टार होटल जणा पड़छ बैकग्राउंड
ଜଣା ପଡୁଛି
हां सर पर्दा जणा पड़छ
ଅଛନ୍ତି ସାର୍ ଆମେରିକାରେ ଅଛନ୍ତି
अरे अमेरिका रे जाइया भीतर पळै जंती
ପାଖରେ ଅଛି
ସାର୍ ହନଲୁଲୁ
ଯା କହିବେ
प्रशांत ठीक रे कहि परिबो कोठी अछन
ସେଇଟା ଆପଣ ପଚାରନ୍ତୁନି ସାର୍ ଆପଣ ଯୋଉ ଯାଉଛନ୍ତି କଣ କହିକି ଯାଉଛନ୍ତି
लास वेगास